Okay, let's see. We are going to waiting for people to get on. Hi. We're going to wait for some more people to join, but I'm so happy that you're here. We are going to be talking migraine with Dr. Berk from NeuroHealth. And NeuroHealth is a really great program. It's a virtual neurology clinic, and it's kind of one of a kind. So you're able to, it's a service, it's a membership service where you're able to see a headache specialist within 48 hours. And it's been such an incredible tool. My mom is actually a patient of Dr. Berk's with NeuroHealth. And after seeing how quickly she was able to get in with Neura, I wanted to be able to speak with them so more people could find out about the services that they have. So I'm going to let Dr. Berk introduce himself. He's wonderful, and yes, go ahead.
Thank you so much. So I am Tom Berk. I am a neurologist and headache specialist. I did my neurology residency at NYU, medical school there also, fellowship at the Jefferson Headache Center, and I went back to NYU. I just became full-time at NeuroHealth just last week, and for the last 6.5, 7 years, I've been at NYU seeing patients specifically focused on headache. Feel very passionate specifically about virtual care and access as it relates to headache, and I'm happy to answer any questions that you have.
So I'll get things started, and I'm going to ask Dr. Berk some questions, and then if you have questions for him, please feel free to ask as well. But first I wanted to know kind of what's the difference between a general neurologist and a headache specialist, and what makes you and other headache specialists so special?
Absolutely. Every general neurologist has training in headache disorders, just like every general neurologist has training in Parkinson's and other movement disorders, dementia and neuromuscular issues, multiple sclerosis, etc. What defines people who are subspecialists is that they've taken either an additional year or 2 years to really have an expertise in a specific field. So even somebody like me, theoretically, I could see somebody with Parkinson's disease, but I chose headache specifically as an expertise that I really wanted to have, and because I've chosen that, it's something that I spend all of my day doing. All I hear all day long are different kinds of headache disorders, and people who have complicated headache disorders, daily headache disorders, subtleties that don't necessarily fit into one bucket or another, things that overlap, symptoms. Sometimes, if you are going to see a general neurologist, it can be very confusing. Maybe you've tried a number of standard treatments, and your general neurologist may not be familiar with some of the procedures that we have. Some IV medications, some of them, new generation medications. They may have heard or seen some of their colleagues talk about it, but they don't have the same familiarity with it. Sometimes there are rare headache disorders that they wouldn't even know exist, which does happen. And the only way that you can actually get diagnosed is by seeing a headache specialist.
So when would a migraine patient decide that it's time to see a headache specialist if they've been seeing a general practitioner or a neurologist?
Certainly if you've tried a number of different treatments and things just aren't going well for you. If you're not 100% sure what might be driving your headache to begin with. What's at the heart of the matter? What other, maybe non-medical factors aren't being addressed, and sometimes, especially if you're, dealing with a general neurologist, they might not necessarily have as much to say about, how the neck and shoulder play into migraine and what kinds of exercises might be helpful. Other kinds of triggers, whether it's sleep or stress management things, sometimes they'll say, listen, I can give you, triptan medications, I can give you some, basic preventive things like antihypertensives, blood pressure medicines, or, I can give you Topamax. But once it comes to complicated, issues, and you're asking, the doctor, am I so anxious because of the headache, or is the headache, is it, am I getting the headaches because I'm anxious? What's driving what? How do I deal with it? And they might just say, why don't you go and see a psychologist or a psychiatrist, which can be helpful. But sometimes having that perspective and having somebody say, listen, I see this all the time. This is how you understand things best. makes a very, very big difference.
Yeah, and so most of my followers have migraine, and what I discovered later in life is that throughout my 20s I had sinus migraine, which is just a new class of migraine subtype, and it went untreated for those 10 years, and so it was just really bad. So why is it so important to diagnose and treat migraine disease just to prevent it from getting worse or any of that?
Yeah, absolutely. Especially if something is very frequent. We're going to talk about like frequency I think coming up. The better the intervention that you have, especially the earlier on, the less likely it's going to lead to something that's daily and very difficult to treat. And different headaches, different subtypes of migraine, different subtypes of other kinds of headaches are treated vastly differently. Something that works, I mean, that's one of the reasons why patients always ask me, I have a friend where this medicine worked, we just tried it, how come it works for them and not for me, or vice versa? You know, I told my friend to try this, and when she tried it with her doctor, it didn't work. The reason why is because there are subtleties, and those little subtleties can completely change the disease process, what's going on in your brain, what's going on in your nervous system, and based on that, how we need to treat it.
Yeah, so true. And also when it comes to the different types and subtypes of migraine, the treatment is so different. I know like vestibular migraine treatment is very different than if you were to have ocular migraine and all of those different medications. So I find it so interesting. And then, so what's the difference between, so there's been a lot of talk about high frequency episodic migraine and then chronic migraine. And so what is high frequency episodic migraine, and why is it so important to treat high frequency episodic migraine when you are starting to get an escalation of migraine attacks?
Everybody who has migraine has their frequency. For some people, it might be a couple times a year. For some people, it's a couple times a month. For some people, it's a couple times a week or more. And when we think about low frequency, oftentimes people can get away with just having an acute medication, something to use the handful of times a year when they get a really bad migraine, and that's it. And the truth is, many people, if not arguably most people with migraine, have low frequency. That doesn't mean that it's extremely infrequent, but it's certainly less than a few times a month. Once it's once a week or more on average, so 4 to 5 days of headache over the course of a month, that's already where we start to think about whether prevention can be helpful. The cutoff when we talk about high frequency episodic, so episodic versus chronic, basically means having less than 15 days of migraine versus 15 or more days of any kind of headache over the course of a month. And high frequency episodic is where you're getting somewhere between 7 to 14 days. Different people have different cutoffs, but that's the generally accepted cutoff with regards to high frequency episodic migraine. And certainly people who have that high frequency are at a higher risk of developing more frequent headaches, more frequent migraines, and more disability due to it, more loss of function because of it. The worse your migraines get, the worse they tend to get. The opposite is true also. The better your migraines get, the better they tend to get. So you want to, have momentum swing the other way, and that's really the importance of prevention, especially when it comes to higher frequency headaches.
Yeah, that's so true. And so how is treating, you touched upon this a little bit, but treating chronic migraine, it's so different than treating episodic migraine. I mean, I had like a toolkit and the number of acute medications and tools I have for my migraine attacks is vast compared to my friend who has episodic migraine and she just needs a leave.
One thing.
So why is treating it so different, and why is it so important to treat chronic migraine and treat the individual attacks?
Yeah, oftentimes with chronic migraine, first of all, you're having more frequent attacks. And most medications that help acutely for migraine will have a certain cutoff. The more frequently that you use it, there can be a risk for developing what we call rebound medication overuse headache. So that means that you may have more than one acute option for your attacks. Also, your attacks may sometimes have different features. It may be that you have extremely prominent nausea one day and more severe pain on the other days. And for that reason, your doctor might give you an anti-inflammatory, something that's more specific for migraine, like a triptan, or maybe Nurtec or Ubrelvy, which are the GPAT medicines, and also an anti-nausea medicine. And you can sometimes combine or use each one individually. There are, sometimes if there's more musculoskeletal pain, your doctor will say, you know what, add on a muscle relaxant on top of all of that. And a lot of it is, figuring out what will help you in each individual situation. When we talk about chronic migraine, we're definitely focusing on prevention because we want to get the exacerbations, each individual attack down. We want to make sure that your baseline pain, how you feel in between the attacks, is a level where you can function, where you can do, live your best life. And if you're still very symptomatic, even when you're not in the middle of, the throes of an attack, but you're just walking around, it's a regular, vanilla, normal day, and you still can't tolerate lights and sounds, and you're very nauseated to begin with, or maybe very dizzy, that's something that has to be addressed.
Absolutely. And so what are some of the goals for someone who has chronic migraine? And I know we talked about this a little bit earlier, but I think that that's so important for people who are new to chronic migraine, is setting different levels of goals and kind of changing those as you progress throughout your migraine disease.
I think it's great that you asked that. Actually, now that I think about it, one of the questions that we actually ask in our intake form at NeuroHealth is, what are your goals entering into this program? And it's an open-ended question. And it's something that allows us to really wrap our heads around where you are at this point. Everybody's goals are going to be very different. For somebody who has, you were saying chronic versus, episodic even, somebody who has episodic migraine, it might be, I sometimes get these terrible attacks and I don't know what to take because the over-the-counter medicines don't help me. Or my doctor even gave me 1 or 2 different medicines and those haven't worked. And we have to figure out a medicine, and you take it a couple times a year and you're fine. If it's higher frequency episodic migraine, it's what is something that can make it so that way I don't have a couple attacks a week, I get maybe 1 or 2 a month at the most. And working with the triggers that I have. When it comes to chronic migraine, so much of it is, how do I feel in between the attacks? How do I have fewer exacerbations? How do I get my life oftentimes back in order? Because you can 100% be disabled due to migraine, which can sometimes be surprising for people to hear, but we see it all the time. And how do I get my life back? What does that mean? How do I feel okay? What exactly does that mean? It's different for everybody. Everybody's individual situation is different as it relates to their family, as it relates to work, as it relates to their lifestyle, and your goals are going to be unique. And oftentimes when you're coming and talking to a headache specialist, we keep that in mind, and we have to understand, okay, you know what, we're not going to give you this medicine because that's not going to work with your lifestyle. We're going to try something else that maybe, has somewhat, less efficacy theoretically, but can work better with your lifestyle and might actually just, agree better with you, fewer side effects, those kinds of things, trade-offs like that. And that's how we can come up with an individualized plan.
Yeah, and I think that's where I got so lucky, is that my doctors both at UCLA and NYU looked, and we discussed what my goals were, and mine really were, I want to get back to work, I want to be able to be active. And so it was like, let's put some polytherapies in place so that you can tolerate light better. Let's get you on Diamox so you're not dizzy all of the time, so that you can go out and be more active. So it wasn't, let's make your migraine attacks go away, but let's make your interictal period and your baseline pain more tolerable and those baseline symptoms livable so that you can function. And then once we got me to that point, it was more, let's add more medication so that your attacks aren't so debilitating.
Exactly.
So it's never, my goals have never been make migraine go away, because it never will. Let's talk about NeuroHealth some. For those who have recently joined, I'm with Dr. Berk from NeuroHealth, and just how does patient care differ at NeuroHealth than it would at a traditional neurology office or at a hospital? I think the biggest difference that I saw was when, again, to use my mom as the example, she has vestibular migraine and has been putting off getting care for 7 years. And when she finally was like, I need help, now. I couldn't get her in to see a vestibular specialist or a headache specialist until August, and this was back in April or early May. And then I was able to get her in to see you within 48 hours, which was amazing. And then she was like back to her feeling good.
Good.
So let's talk about NeuroHealth and how y'all help patients like
Absolutely.
my mom or other people.
I think it's in three ways. I think that convenience is a big part of it. We basically go to you. I mean, we're not literally there, but we are virtually there, and that's one major part of it. We do strive to be able to offer you an appointment within 24 to 48 hours. Certainly follow-ups as quickly as you need them, and we have a whole team of people who are specialists, people who have worked in headache centers. Headache specialists, even PAs and NPs who are themselves headache specialists, have worked for years in headache centers throughout the country, and wherever you are, we hope to be able to offer you something. Number two is that we're very comprehensive. In addition to thinking about medical issues and medical care, we try to develop for you what we call an individualized care plan, and that might mean that we are going to send to you through the app specific exercises for your neck and your shoulders. Maybe specific things as it relates to stress management. Biofeedback, for instance. We have a care coach who comes to check in with you either every week or every other week for 10 or 15 minutes to help there be support for you, and it's somebody who you can reach out to literally 24/7. Same with your care team, with your clinical care team, not just with your coach. If you have medical questions or issues, we're there for you, and we do send we're there answering your messages as quickly as we can. We try to be very comprehensive in that way. We're coming up with a number of other care plans, specifically one as it relates to vestibular migraine, one as it relates to like CSF leak, another as it relates to sleep. These are things that so many people have issues with, and you don't necessarily have something comprehensive or people who even can speak the appropriate language, who can use terms that you can understand and can give you the right diagnosis. And I would say that the third part of it is that we try to give you the highest level of care. We are experts in this field specifically, and we have come up with plans that are specific for your diagnosis. We try to give you the appropriate diagnosis and the appropriate treatment based on that. We know the newest research. We're publishing, actually, we're presenting this week, the American Headache Society conference, scientific conference in Denver. We're presenting some of our initial, data that we have that shows the effectiveness of virtual care. So, we are trying to put forward, the next, level of scientific information as it relates to virtual care for headache. So that's our goal, and that's why we're different.
Okay, that's so wonderful. And so just now I see people are starting to ask questions. So first of all, NeuroHealth, it's spelled Neura Health, and the website is neurohealth.co. And they are located in the US, so you can join NeuroHealth in all 50 states and Washington, D.C. And it is virtual. So the Dashing Ginger, they do virtual appointments. So now we can start taking some questions. I'm going to scroll through to see. And we're going to start taking some questions about migraine. Someone wanted to know if it's normal to constantly feel some type of pain, even if it's just a little.
It is not normal. It is not normal. Is it something that can be treated? Definitely. It is definitely not something that you should have to deal with. And it's not something that somebody should tell you, just deal with it. So I would definitely not tell you that this is a normal thing. Most people in the world do not walk around with some kind of headache all the time. And I definitely think that you should, find a good headache specialist. We'd be happy to help you get to the bottom of what's going on.
Yeah. And then I would say, like, for me, it is normal for me to constantly feel pain, but I have very severe migraine, and so there's there's literally, I don't think there's anything I could do or take at this point to make my baseline pain get any better. But it's very low compared to what it was. So let's see, I'm going to start seeing if there's other questions. So other people wanted to know about health insurance. So Neura Health does not, insurance is not required.
It's not required. We take, we are in the process of getting as many insurances as possible. There are already a number of insurances that we take. It's, there are two separate fees. One is a membership fee, and one is for appointments, and insurance would pay for any appointments that we would have, whether that's an initial appointment or follow-ups. And it's something that we're expanding on a week-to-week basis. Just a few weeks ago, there was like one insurance, and now there are a wide variety in different states. It's a tedious process. It's a long process. It's a very bureaucratic process, and we have great teams of people that are getting as many insurances as possible. And like I said, state by state, you could be Medicare in one state but not in another, Cigna or United in one state, and each plan individually. So these things just take time. But our goal is to take as many insurances as possible, if not every single one.
That's great.
So that is definitely what our mindset is, and it takes time.
Yeah, that makes total sense. So Sandog wanted to know, how often do you find Chiari?
Chiari. Yeah,
I'm
sure.
sorry, I mispronounced that one.
That's okay. Yeah, we do find it sometimes in people, and the question is, when is it relevant, and when is it, in other words, when is it really the cause of the headaches, and when is it not? And so often, it really depends on the kinds of symptoms that you're experiencing. Sometimes you can have migraine, and we incidentally find something. It can be a Chiari malformation. It can be, sometimes an arachnoid cyst. Anytime that you scan some part of the body, you will usually find something. Just like if you were to look at all of your skin, you would find little things here and there that come up, and that's normal. Not every organ is perfect. You would definitely find this same thing with the brain or the lungs or the liver or whatever it would be. And the question is, when is it considered something that's an incidental finding, and when is it really relevant to the discussion at hand? There are guidelines, by the way. There are well-respected guidelines based on the American Academy of Neurology, the American Headache Society, for when imaging is necessary and when it's not. We follow all of the guidelines, whether it's in relation to imaging or blood tests, or when to use specific kinds of preventive or acute medicines. We follow the respected scientific guidelines. And in some situations, it's definitely relevant. In some, it's something that we see where it's a borderline. How often do we see it? Not that often, to be very honest. The vast majority of the scans that we see show a relatively normal brain, or signs of migraine, which are things like hyperintensities, these little white spots that you'll see, usually in the white matter, and they can definitely imply different things based on the location, based on the size, based on the shape of it. They can tell you what is caused by it. And people who have migraine, we see ones that are consistent with migraine. So with Chiari, if it's something that we see, we definitely look back and we think to ourselves, is it possible that this is relevant? How significant is the Chiari? Is it something that's borderline? Is it something that's multiple millimeters? And what basically this thing is, I should just describe it. There's an area of the brain it's really part of the skull. It's called the foramen magnum. It's the big hole where your brainstem connects to your spinal cord, and all of your central nervous system, becomes one entire whole. And it's possible for the bottom part of your brain, the part in the back, which is the cerebellum, to lie very, very low, and even to start to, lie so low that it's coming through that foramen magnum. Depending on how much is coming out, that's what we call a Chiari malformation. And sometimes it can be relevant, sometimes it is a problem in and of itself, Sometimes there's something else that causes it. For instance, it can be a spinal fluid leak that causes it. Sometimes it can even be what we call intracranial hypertension, so pressure being too high. So being pressure of the spinal fluid in the skull being too high or too low can cause these things. Sometimes people are born with it, and that's where we call it, a true malformation, and sometimes it's relevant and sometimes it's not.
See, and this is why you see a headache specialist to treat these types of conditions as opposed to a general neurologist, because they know everything about headache disorders. Exactly. So someone was wanting to know about migraine being genetic. And let's talk a little bit about migraine, the genetic disease, and then the other kinds of comorbidities and causes of migraine.
100%. For the most part, and there was actually a recent study that came out, I'm going to say about 2 months ago now. Initially, we had recognized about 28 different genes that were associated with migraine. Another 100 plus genes were just found to be associated with migraine also. For the most part, if you were to ask any headache specialist, if you have migraine, they would say, if we were to test your blood with these genetic tests, these are not commercially available, they're not ways that we can prove or disprove that you have migraine, but if we were theoretically to test your blood, we would see in your DNA one of these genes for migraine. If you have a predisposition for migraine, that's what basically allows migraine as a thing to happen to you. People who don't have migraine don't have those genes. And about 1 in 5, 1 in 6 people or so in the world have migraine. All of those people have genes for migraine. It's very strongly familial. And that's, oftentimes, almost always, you'll be able to point to somebody else in your family and you'll say, oh, it's your fault. You're the reason why I have my terrible migraines. That is a separate issue. That's one thing. And then a separate thing is, why do you sometimes experience a migraine now versus not yesterday and not tomorrow? And we think about what kinds of things could bring out a migraine, could trigger it. People describe that in a number of different ways. Some people talk about a threshold that you might have based on this genetic predisposition, and enough triggers start to happen, start to cause that threshold to be low enough that migraine starts to happen. I think that's a convenient way to just kind of wrap your mind around what happens in your brain during a migraine attack and why sometimes you'll have it and sometimes not. Oftentimes, even people who have very consistent triggers, they'll notice on a day-to-day basis they might be exposed to the same thing and have very different experiences. And sometimes it brings out a migraine and sometimes it just doesn't. And the reason why is because of context. It might be that on the day that you had a migraine, you also weren't sleeping super well, and you also were a little dehydrated. There's something that was stressing you out a little bit more, and all of those things came together and caused the migraine. Meanwhile, the other day, when you were exposed to that same thing, you didn't have that same context.
Yeah, I like to think of it as a glass of water.
And
as that glass of water
great
fills,
analogy.
then you
At some point.
know. Yeah.
Mm-hmm.
And usually my worst day is when it rains.
Yeah.
When it rains are my bad days.
Mm-hmm.
So let's go through. So some people are asking about, I see this a lot. They feel like they've tried everything possible to treat their migraine disease and they're not really getting a lot of help or relief. What are some things that they could try to do to get relief, even if they've been trying for 20 plus years?
Mm-hmm. Well, first thing is there are newer medications that are coming out, even new ones that are just, very closely, very soon to be approved by the FDA. So there are sometimes new treatments, sometimes it's a combination of treatments, sometimes it's the combination of medical and non-medical treatments. All of these things, in the right combination, can sometimes finally make a dent and actually really improve your situation. Sometimes the issue is you actually have the wrong diagnosis. That happens. And I'll tell you, even as a headache specialist, even the best headache specialists will sometimes be fooled. And we thought you had migraine for years, and in the end, we only realized afterwards it was something else. New daily persistent headache. Oh, I didn't realize it started on one day years and years ago, or spinal fluid leak, or something else that's related to the sinuses, or something that could be a secondary cause. And sometimes we can get fooled. So definitely, if things aren't going well, I always ask myself, what is it that I could sometimes be missing? Oftentimes I'll even ask my colleagues, or I'll speak to a mentor of mine, and I'll say, in this kind of situation, what do you think? I'll describe, the story to you. Is there something that I'm missing? And the truth is that even with trying so many standard medications and so many standard treatments, there are things that we'll use sometimes that are, a little off the beaten path. Sometimes we'll use specific kinds of anti-inflammatory, antibiotic medications. We'll use minocycline. It sounds a little crazy, but we'll do it sometimes. Sometimes, if you have specific, residual symptoms, maybe everything is better, but you're still so sensitive to light. Maybe something like, Namenda, which is memantine, could be, the answer. Every situation's a little different, and definitely in that situation, if you've tried so many different options and treatments, seeing a headache specialist, if you've seen a headache specialist, sometimes even going to, a larger, academic center, someplace like Jefferson, someplace like maybe even, NYU, maybe even thinking about, a place like Diamond. There are places where they see people who have had headaches that are daily for years or decades, and sometimes it's IV treatments that you need that you haven't tried before. So there are options. Nothing's ever a guarantee, but oftentimes there are things that you haven't tried.
Yeah. And again, this is going back to someone is wanting to know, how often is migraine mistaken for sinus headaches? And how can one start finding a diagnosis? Because I know that's such a new thing that is coming out in research. I haven't even made a video about the study that came out about sinus migraine.
So one of the things that you definitely want to make sure is that you have the right diagnosis. And a lot of it is going to be based on your symptoms. And having sinus congestion or runny nose, sometimes that can be actually a consistent symptom of migraine, just like you have inflammation and irritation of the little nerve endings in the back of your eyes and your ears that cause your sensitivity to lights and your sensitivity to sound, and around your brainstem, which is like the nausea center of your brain, you have little nerve endings that go from the outside of your brain into your sinuses too, and sometimes that can cause sinus problems and sinus issues. Oftentimes, imaging does lead you one way or the other. So if something is funny about the kind of headache that you're experiencing, that's really where imaging is going to come in, and depending on the right image, depending on what we see with your sinuses, sometimes it'll show that there's really a problem. Sometimes your sinuses will be totally open and clear. Oftentimes, neurologists, headache specialists have to work hand in hand with ENTs. They will, scope out the sinuses. They'll make sure that your sinuses look totally clean and clear. I would say oftentimes the opposite happens, and you talk, sometimes about sinus migraine. A lot of times people think that the main problem that they have is their sinuses, and they don't realize that what they're actually experiencing are migraines that also happen to affect their sinuses. I think it's, if anything, the misdiagnosis happens more often than not the other way around. And the American Migraine Foundation is actually doing, a bit of an educational sprint, talking to people about, rethinking what some of their sinus symptoms might be, and telling them, by the way, shockingly, migraine might be affecting your sinuses. And I think that there's a tremendous amount of education that needs to be, put to the public. Surprisingly, the United States is one of 2 or 3 countries in the world that actually markets medications for sinus headache. So it's a problem, because so many people don't realize that actually it's migraine that's there, that's that's affecting your sinuses, and being on sometimes appropriate migraine treatments and medications can be the answer.
Yeah, and that's how I was for 10 years, and I think I took Tylenol every day, which was horrible, and probably put me into rebound, but I had no idea.
Exactly.
So let's talk about migraine treatment during pregnancy and how that treatment differs than when you aren't pregnant.
Absolutely. I mean, the first thing that I would say with regards to pregnancy is most people who become pregnant, especially as you go through the 2nd and 3rd trimesters, pregnancy really tends to improve migraine for the vast majority of people. That doesn't mean everybody, and nothing is a guarantee. The first trimester can be sometimes a little iffy, but usually not terrible. That being said, obviously there are going to be limitations with regards to the medications that we use. And some are more straightforward, and some are much less straightforward. For instance, what we try to go by are FDA categories with regards to medications. FDA, for decades, categorized safety medications based on a letter system, which was very convenient. We've kind of moved away from that. I would say most headache specialists will still use the data that we know based on pregnancy information. Sometimes it's human data, sometimes it's animal data, and that's where we'll make our recommendations. So the vast majority of preventive medications are things that we would want to avoid. So honestly, becoming pregnant means that you should have a discussion with your neurologist, your headache specialist, and say, by the way, I'm thinking maybe sometime in the next 6 months, I might want to try. Do you think that there are certain medications that I should even start coming off of early? And there are certain medications you absolutely cannot be on even a few months before pregnancy. For instance, the new injectable medications, Aimovig, Emgality, Ajovy, the IV Vyepti, all those monoclonal antibody CGRP medicines, they are considered not safe in pregnancy, and they have long half-lives. Their half-lives are about 28 to 30 days or so, and we consider being off of a medicine fully has 5 half-lives off of medicine. So each half-life means that there's half of the amount of medication in your system. So once it's 5, then it's considered negligible. So for the injectable medicines especially, you do have to be off those medications for about 5 months before pregnancy planning. So it's definitely something you should take in mind. It doesn't necessarily mean that being on the medication is a bad thing for you or for the fetus. It just means that it's something that we want to avoid if at all possible. The issue is these antibodies can theoretically interfere with normal bone structure and development. Mm-hmm. With regards to acute medications, many are okay and some are not. So for instance, anti-inflammatory medicines, depending on where you are in pregnancy, are either bad or very bad. So we really try to avoid things like ibuprofen, Aleve, Advil, those kinds of medications. Steroids, depending on the kind of steroid, may be fine and may be actually totally and completely safe. So it's the opposite with regards to the anti-inflammatories. And sometimes if you're in a really bad rut, it's something that you can use. Something like Botox is very controversial. I would say the vast majority of neurologists and headache specialists would not perform Botox while you're pregnant, but they would prior to pregnancy. There are definitely some that will still feel fine, giving you, doing the Botox injection while you're pregnant. There's a theoretical risk, which is quite low, but there's also kind of a heebie-jeebie thing. It's like, I don't know, giving this person botulinum toxin and they're pregnant doesn't sound right. So, it's something that some people have a lot of, hang-ups around. Triptans, also very controversial. Most OBGYNs will say the rare use of triptans is okay during pregnancy, and most neurologists really don't love using triptans in pregnancy. For the most part, if you need injections, lidocaine specifically, not with a steroid and not with bupivacaine, can be effective. Many of the new devices like the Cephally or the Norivio or even the GammaCore VNS device can be safe in pregnancy and are generally considered safe in pregnancy, which is a good thing. And some preventive things, Periactin, which is ciprofloxacin, it's a kid's migraine preventive medicine, very effective, especially in kids. That can be something you can use. Can be a little sedating, so you want to take that before you go to sleep. If insomnia and migraine, seem to be like, worsening each other during pregnancy, sometimes it's a great option. And Tylenol is considered category B in pregnancy. It's usually not the strongest medicine, but some anti-nausea medicines like Zofran and Reglan can be pretty effective. Other kinds of vitamin supplements that a lot of people use are helpful too. So it's definitely a discussion that you want to have with your neurologist and headache specialist as well before you become pregnant. They're definitely good options, but there are limitations obviously to what we can give you in pregnancy.
That was the most comprehensive answer I've gotten about migraine treatment and pregnancy. So thank you. And as I'm starting to feel some auras coming on, we have some people who are asking about auras, and if we could take a few minutes to talk about different migraine auras. And one person, Tropical Flamingo, wanted to know what causes zigzags and other patterns with visual auras, and then if we could kind of segue that into talking about the other types of auras and where they how they come to be.
Absolutely. So aura in general is something even separate from migraine. Not everyone that has migraine has aura. Basically what will happen in the brains of people who have migraine with aura, and this sometimes will happen totally separate from the actual painful attack. It's possible just to get the aura and no migraine, no pain associated with the migraine, is an abnormal electrical, spread over a specific area of the brain, and the part of the brain that's affected is the part of it defines the symptoms that you start to notice. The back part of the brain, which is the occipital lobe, for whatever reason, is the most aurogenic. So it is the part of the brain that tends to have these aura symptoms more than just about any other part of the brain. And for that reason, people experience more visual aura than anything else. Now, why is it that some people have specific zigzag lines and other people have colors, and for other people it's distortions or small things look big and big things look small, what we call Alice in Wonderland syndrome. For some people it's what we call a scotoma, which means an area that you can't really see through that moves all across your field of vision. It's different based on what parts of the brain are especially even the occipital lobe, the visual cortex, is affected. And it's fairly stereotypical for most people. So most people will say it's that same aura symptom that I've been experiencing. And for some people it's very different. So I do think, if it's, for instance, the sensory part of your brain, then you can start to feel numbness and tingling. And again, typically it spreads, it doesn't stay in the same place. It moves from your arm to your hand, spreading all the way up to your face. Sometimes it can even affect, it can cause vertigo. It can affect word finding. It can affect speech. It can be sometimes, very profound and really look like stroke. Some people have what we call hemiplegic migraine. It can affect, exactly. It can affect your motor function. So depending on the part of the brain that's affected, that's the symptom that you'll experience.
So if the auras are, it's different parts of the brain that are affected, and so if you have multiple auras at a time, different parts of your brain are being affected at that time.
Absolutely. Sometimes it's not even the brain itself. Some people will differentiate between when they have a visual aura and they see it on the same side in both eyes, or if they only see it in one eye. And sometimes that'll be a distinction where we'll call it, if you only see it in one eye, a retinal migraine, as opposed to if you see it on the same side in both eyes, we'll call that just your standard visual aura associated with migraine, because sometimes it's the brain that's affected, sometimes it's the eye, it's the retina that's affected.
Okay, that's so interesting. And that also, and we're kind of going to be wrapping up, but someone had questions about abdominal migraine and how that's affected. And I always thought of it being similar to vestibular migraine, and what you're saying about retinal migraine, with it affecting a certain part of the body. So vestibular is the inner ear, and so then with abdominal, that would be of the stomach.
So the question really is, even with vestibular migraine, is it really the vestibular organ that's like in the ear? Or is it what that area, kind of feeds in the brain? And there are debates that go back and forth based on whether it's considered a central, kind of vertigo or more of a peripheral kind of vertigo. Based on the symptoms that most people experience, it's more affected, with the brain.
Okay.
And I would say even with abdominal migraine, it's oftentimes more the brainstem, which is the area of the brain that is in charge of digestion and the stomach, more so than the actual stomach itself. although the retina really is basically brain tissue. The optic nerve is like brain tissue that extends to the back of the eye. So it's very interesting that way, which is why that's probably more the exception that proves the rule. And abdominal migraine is something we see primarily in kids or younger people, and it can be a sometimes very severe manifestation of migraine. It needs to be treated in its own way.
Okay, interesting. And final question, because this is something that I was laughing with Dr. White about and other headache specialists on Twitter. Can you hear the crunch during Botox? How loud is the crunch when people get Botox?
So the question is, can you hear it or can you feel it?
Yes, sorry.
So my opinion on this, and this maybe is a little controversial, and I would love to hear Dr. White's opinion on this also, but my opinion about this is that you can hear it, but I can feel it.
Okay.
And, if I hear it at all, it's very, very, very low. I'd be surprised if somebody next to you can actually hear it. That, I think, would be, the differentiating factor. That would, tell the tale of truth. Is it something that you hear or feel? I definitely feel it. And the question is it a muscle thing or is it a needle issue? And I've heard both sides of the argument that way. Some people say it's just that the needle becomes a little bit duller as you go and do more of the injections, and some people say it's because the muscles in that specific area are really tense or dehydrated. A lot of theories around it, but it is a real thing.
Okay. I'm still fascinated by the Botox crunch. Well, thank you everyone for joining. Thank you so much, Dr. Berk. And again, this is Dr. Berk from Neura Health. You can follow Neura Health on TikTok, Instagram, Twitter. It is a virtual neurology clinic that treats headache and migraine disorders, and it pairs you with a headache specialist and with a care team virtually. So if you live in a small town and you have not been able to get in to see a headache specialist, you can sign up for Neura Health and get to see a headache specialist within 48 hours. And as he said earlier, they are beginning to accept insurance. So they have the membership program, but insurance is accepted. So this is such an incredible program for people who have migraine, especially if you're having a difficult time to get in to see a headache specialist. You may be able to get to see Dr. Berk within 48 hours. He could be your headache specialist. So everyone check out Neura Health. It is so wonderful. And thank you so much for joining this TikTok Live. Now I got to figure out how to turn it off. Bye-bye.